In this presentation, we will be discussing eating disorders within the male population. This presentation was created by Catarina, Breanna, Shelby, Autumn, and Sintia. In this presentation, we will begin by introducing eating disorders within the male population. Firstly, statistics and general information about these disorders and how they impact the lives of males will be discussed. Then the characteristics and symptoms associated with these disorders in the male population will also be discussed. Causes and risk factors, such as genetics and sociocultural factors relating to eating disorders in men, will be introduced and explained. We will then move on to potential therapies and treatment methods for men with eating disorders. We will discuss psychotherapy and have included a case study involving cognitive behavioral therapy and eating disorders. Lastly, we will touch on how the media portrays eating disorders in men and the influence it has on their body image.
While eating disorders are often portrayed as an illness only affecting the female population, research suggests that a significant proportion of those with eating disorders are males. Common eating disorders such as anorexia nervosa, bulimia nervosa, and binge eating disorders are also prevalent in the male population. According to a study conducted by Wilson, males account for roughly 10% of patients suffering from anorexia nervosa and bulimia nervosa. However, other researchers suspect that up to 25% of reported anorexia and bulimia cases are males. Among the eating disorder diagnoses, binge eating disorder has the highest ratio of males to females. Males make up about 40% of individuals with binge eating disorder. The lifetime prevalence rates for eating disorders in males are 0.3% for anorexia, 0.5% for bulimia, and 2% for binge eating disorder. Overall, the National Institute of Mental Health reports that roughly 1 million males struggle with eating disorders, which is likely an understatement. Many men with eating disorders go undiagnosed because of a personal reluctance to seek help due to social stigma and a lack of awareness in the community and by healthcare practitioners. It is also important to note that the age of onset for eating disorders in the female population is in the adolescent years, between the ages of 15 to 18, while men tend to develop eating disorders at an older age. Specifically, the average age of onset in males is 17 to 26 years. This delayed onset may be another reason why eating disorders in the male population often go underreported.
There are many characteristics associated with males and eating disorders. Studies have shown that these particular characteristics are more prevalent in men than women. By characteristics, we are referring to the objective signs associated with eating disorders, specifically signs which may be obvious to other individuals such as family, friends, and healthcare providers. The most common ones include a preoccupation with bodybuilding, weightlifting, or muscle toning, even when injured. During these activities, males may experience muscular weakness due to decreased testosterone levels. There is also a common trend in the use of anabolic steroids in hopes of achieving a certain muscular build and aesthetic. It is also common to exhibit a certain level of anxiety or stress when a workout is missed, experience muscular weakness and fatigue. An overall decreased interest in sex or fears around sex in general is also another characteristic among males. Lastly, males suffering from eating disorders may engage in episodes of binge eating, purging, and laxative use, which may result in unhealthy or drastic weight loss and/or weight fluctuations. There are also common symptoms associated with eating disorders, many of which are common in both men and women. By symptoms here, we are referring strictly to the subjective experiences, which may only be recognized by the individual suffering from the eating disorder. Some of the most prevalent ones include a chronic desire or need to diet despite being hazardously underweight, an unhealthy obsession with calories and fat content in food, a desire to engage in ritualistic eating patterns such as cutting food into tiny pieces, eating alone, and/or hiding food. Another symptom is a continued fixation with food, recipes, or cooking, where the individual may cook intricate meals for others but refrain from partaking in eating them too. Going through a depression or lethargic stage is also very common, which may lead to an overall avoidance of social functions, family, and friends, and becoming isolated and withdrawn. Lastly, males suffering from eating disorders may experience feelings of a loss of control over food consumption and weight gain.
There are several causes and risk factors that may influence males to develop an eating disorder. However, it is important to take notice that there is no single cause that increases the likelihood for males to develop an eating disorder. Despite any beliefs that eating disorders only develop in males' adolescent years, it can happen at any age. The known and hypothesized causes for eating disorders in males include genetics, biochemistry, psychological factors, and sociocultural influences. We will go into further detail about these causes in the following slides. Genetics have been found to have a contribution to eating disorders. Eating disorders often tend to run in families, as in several studies it has been found that there is a higher chance of having an eating disorder if someone in the family has been diagnosed with also having one. Therefore, eating disorders may be hereditary due to inheritable influences on appetite and impulsive controls. There are certain chemicals and neurotransmitters in the body that are found at abnormal levels in the body of those with an eating disorder. High levels of cortisol has been found in people with eating disorders such as anorexia and bulimia. Cortisol is often considered the stress hormone, as high levels are often found during stressful life events, resulting in an increased heart rate, respiration, and blood pressure. Increased levels of serotonin are also found amongst individuals with eating disorders, and high levels are known to cause them to be in a constant mental state of stress. Psychological factors are also related to the development of eating disorders in males. These psychological factors include body dissatisfaction or a negative body image. This can lead one to develop a low self-esteem, and men may feel as if they are not good enough. Always aiming for perfectionism, depression and anxiety, difficulty coping with challenging life situations, difficulty expressing oneself and their emotions, obsessive compulsiveness, which is being obsessed with losing weight and having the perfect body image, childhood, physical or sexual abuse, and having autonomy and control. For example, in most societies, males are portrayed and have expectations to be in control. When dealing with a certain issue that is beyond their control, such as an eating disorder, men can put this pressure on their bodies through excessive dieting in order to feel that sense of control or autonomy. Sociocultural influences associated with the development of eating disorders include peer pressure, family or relationship problems, social pressures on looking a certain way due to beauty standards, so being lean and thin is often thought of as healthier and more attractive, media's portrayal of what the perfect or ideal male body looks like, which often promotes an unrealistic body image, the media's influence on dieting and striving for a lean physique. Male athletes are also more likely to develop an eating disorder, such as dancers, gymnasts, and particularly those that greatly emphasize on body and fitness over the ability to play a sport, such as bodybuilders and weightlifters. And body dissatisfaction. This may be due to bullying and or discrimination that overweight or obese individuals face in today's society.
The basic principles of treating eating disorders focus on several goals. These goals are to correct life-threatening medical and psychiatric symptoms. This may involve weight restoration and the treatment of comorbid conditions. To interrupt eating disorder behaviors such as food restriction, excessive exercise, laxative use, binge eating, and purging. To challenge negative thoughts related to weight and shape, and to teach ways to adapt to socio-cultural expectations, and to establish a plan to prevent relapse. Treatment for eating disorders may involve either an inpatient or outpatient treatment plan. Inpatient treatment is required for people who are medically and psychologically unstable as determined by an unstable or depressed vital signs, laboratory findings, and complications due to coexisting medical conditions. Inpatient programs provide the most intensive treatment, which may include the monitoring of vital signs, nasogastric feeding, life skills counseling, controlled therapeutic meals, and psychotherapy. Outpatient treatment is used for people who are not at immediate medical danger and do not require hospitalization. This form of treatment takes place over several hours per day, a few days a week, and generally includes nutritional education, access to external support groups, and psychotherapy. is indicated an important component of both inpatient and outpatient eating disorder treatment plans is psychotherapy. Psychotherapy is the use of psychological methods and regular personal interaction to help improve an individual's well-being by mitigating troublesome behaviors, beliefs, compulsions, thoughts, or emotions. Several types of psychotherapies have been shown to be effective methods of treating eating disorders. Types of psychotherapies such as acceptance and commitment therapy and dialectical behavior therapy focus on changing behaviors or actions instead of thoughts and feelings, while family-based treatment includes family members as an essential part of the treatment plan. Family-based treatment also doesn't focus on the cause of the eating disorder. Instead, it focuses on weight restoration and reestablishing eating habits to promote recovery. Cognitive behavioral therapy and enhanced cognitive behavioral therapy, on the other hand, is a symptom-oriented therapy focusing on modifying the beliefs and cognitive processes that maintain the eating disorder behavior. For this reason, cognitive behavioral therapy is the leading empirically supported treatment for bulimia nervosa, binge eating disorder, and anorexia nervosa. A study conducted by Lajotson aimed to evaluate the effectiveness of an outpatient internet-based cognitive behavioral therapy treatment plan for bulimia nervosa and binge eating disorder. The study involved a randomized control trial in which 73 participants were older than 18 years, had a BMI of at least 18, were not moderately depressed or suicidal, and met the diagnosis of bulimia nervosa or binge eating disorder. The participants were randomized into treatment and control groups. The treatment groups received guided cognitive behavioral therapy, which focused on addressing the cognitive symptoms associated with eating disorders, as well as the behavioral symptoms related to food and appearance, while only minor attention was paid to the control group through weekly assessments of eating behaviors. Assessments were conducted at screening, pre-treatment, post-treatment, and a 6-month follow-up session. The assessment techniques used were semi-structured interviews that measured and analyzed shape concerns, weight concerns, eating restraint, drive for thinness, and body dissatisfaction. The results of this study indicate that 46% of the participants who completed the treatment no longer binged or purged, and there was a 64% reduction in objective bulimic episodes. In addition, 33% of participants experienced improved outcomes related to restraint, eating, and weight and shape concern, and 46% of participants improved on the indices of depression, self-esteem, and general life satisfaction. With reference to the Pedro scale, the study has a high degree of an internal and external reliability since eligibility criteria were specified, randomization was used, blinding of subjects occurred, and statistical comparison of at least one key outcome was calculated and reported. However, there were several limitations to this study. For example, a larger sample size would have yielded more power in analysis. A follow-up period longer than 6 months is desirable, and a placebo or another comparable active treatment for the control group would have been informative. With reference to the topic of this presentation, which is eating disorders in males, the cognitive behavioral therapy used for male participants in this study may have been more effective if it was specifically geared towards males. For example, the assessments used could have not only measured concerns about weight and shape, but also concerns about masculinity. Also, a history and current use of muscle-enhancing supplements, such as steroids, should have been considered. Other possible measures of body image disturbances in males that could have been helpful in this study include drive for muscularity scale, muscle appearance satisfaction scale, and male body attitude scale.
In the media, the projection of only women experiencing eating disorders is very commonly seen. The media will encourage women to seek professional care to assist them with their disorder. However, eating disorders in men is expressed through the media differently. Because of the stereotype regarding males and their masculinity, being diagnosed with an eating disorder may feel like an acquired weakness that the male gender does not associate with, according to to societal norms. Additionally, the media may imply that only certain groups of men can get an eating disorder, including one's sexual orientation. In a media analysis conducted by McLean and colleagues, it was found that the various media statements regarding this topic implied that the majority of male sufferers were gay. Some articles even included that some heterosexual males reported being uncertain of their sexual orientation because of their diagnosed eating disorder. In reality, studies suggest that only approximately 42% of men with an eating disorder identify as gay or bisexual. Media portrayal may make seeking professional help for an eating disorder a shameful and unmasculine act. It may deter a male from receiving help because the thought of being diagnosed with a female condition does not fit into these societal norms. Lastly, as eating disorders are mainly portrayed by the media to affect women, the majority of therapies and treatment methods are geared towards the female body. This may also impact the work of health professionals involved in the rehabilitation of eating disorders. By mainly focusing on women and eating disorders, a health professional lacks the knowledge and skills to help a potential male client who suffers from an eating disorder. As mentioned previously in the presentation, the media has a great impact on male body image, of which can lead to the development of an eating disorder. The media portrayal of men has increased over the past 30 years and has reached the point where the male body in the media is not attainable unless substance use, such as steroids, occurs. The stereotype associated with the male gender is for one to appear strong and invulnerable to virtually anything that may impact them. As the media continues to provide men with images and advertisements of the ideal body, men do suffer from depression and body dissatisfaction. This negative body image can eventually lead to a male developing the various eating disorders discussed previously in this presentation.
As discussed in this presentation, eating disorders are experienced by both females and males, contrary to popular belief. The cause of eating disorders within males is multifactorial in nature, including genetic, psychological, and sociocultural components. Underdiagnoses of eating disorders in the male population, in particular, occurs as the result of strong media influences and social stigma. Even though the severity and extent of eating disorders in the male population is hard to determine based on statistics, it is an increasing issue which needs to be addressed. Research suggests that psychotherapy is an important component of both inpatient and outpatient therapies, specifically cognitive behavioral therapy, which focuses on altering the psychological and behavioral components that maintain unhealthy eating behaviors, has been shown to be an effective treatment for males suffering from bulimia nervosa and may potentially be applied to other disorders as well. With this being said, the challenge associated with reducing the number of males suffering from eating disorders is not related to a lack of available treatments. Since numerous psychotherapy treatment plans have been shown to be scientifically effective, the challenge is related to increasing the number of male eating disorder cases that are actually reported and diagnosed. This can be done through eliminating social stigmas attached to eating disorders, as well as increasing public knowledge about this topic. As health science students and potential healthcare providers, we all can play a role in accomplishing this goal. Thanks so much for watching our presentation. We hope you enjoyed it and learned something new. Thank you.